Thank you.
Good morning. Thank you, Swapnila ji. Thank you. Happy Saturday morning to all of you and a wonderful AIOS conference. We must thank Dr. Partha Vishwas, the scientific chairman, and his whole committee. And we must also thank the headquarters and the office bearers of the AIOS for giving us this opportunity. On the panel, we have Padma Shri. The course is Smart SICS, Technological Advances. On the course, we have Padma Shri Dr. T.P. Lane sir, who is my teacher and guru. My friend Dr. who is also the advisor to the MOS and the BOA, and who is the Director of Medical Education, Maharashtra. My friend Dr. Santosh Bide, who is the Vice President of the Maharashtra Ophthalmic Society. Dr. Parekh-Ten, who is the President of the Maharashtra Ophthalmic Society. SICS is considered as an inferior brother of the phacoemulsification. And it is very true that phacoemulsification is the surgery of the day. And we always keep on striving to perfect our SICS to reach the standards of phacoemulsification. But the fact also remains that in India today, 70% of the surgeons are SICS surgeons. It takes time to learn, especially the beginners, the residents who are doing MS, till they learn phacoemulsification, and a large population of surgeons who are doing SICS today because of the cataracts which are hard brown. SICS remains an all-rounder. After that, I would request Dr. Lane sir and Santosh to say something, and then we will start our session. Dr. Lane sir.
The thing SICS, I think Ragini, SICS is the surgery where the learning curve is very less. And that is the surgery where we start our career in ophthalmology. Secondly, today is the best surgery that whenever we want to learn the ophthalmology, we start from the SICS. And I think we are the teacher, and so we are doing different type of SICS in the in our this one in the institute, and I think that is a very good thing. So with this, I think Ragini, we should go ahead and start your presentation.
Thank you. So there will be various talks in this session. I will be starting with 10 steps to a perfect SICS. Dr. Santosh Bide will be talking on premium IOLs in SICS. Dr. Lane sir will be teaching on complicated case-based scenarios. I will be discussing nucleus delivery, which is different from phacoemulsification in SICS. Topical SICS is something that Lane sir will discuss, and complications in management of SICS will be discussed by Parikshit Gupte sir. So it is important to do a perfect SICS, and like the 10 commandments, I will be discussing the 10 steps to a perfect SICS. So, today the scenario is that it is a cataract-refractive surgery and not a cataract surgery. Every patient comes to you and says that I want spectacle-free vision. What we want is simulation of natural vision for the patient once the lens is removed. There is the advance of flax and new generation IOLs. So all this put together makes cataract surgery very different today from what it was. The basic steps in an SICS are the sclerocorneal tunnel. The tunnel in SICS, because the nucleus is large, always remains a sclerocorneal tunnel unless it is in a child or in a very, very soft cataract which just needs to be aspirated. Capsulorhexis, hydromaneuvers, because you need to decrease the size of the nucleus. Nucleus rotation to ensure a free movement of the lens and a comfortable delivery. The cortex aspiration and the IOL implantation. So these are the steps. The first step is the conjunctival flap. After taking the bridle suture in viscoexpression or not necessary in Blumenthal, the first and the foremost important step is the conjunctival flap. It covers the incision so that there is no irritation, and though it appears to be insignificant, it's very, very important with respect to safety. So as you can see over here, this is the patient whose eyeball is rolled down so as to have access. Essentially, the incision will be at 12 o'clock unless and until there is scarring because of previous pterygium surgery or if there is a bleb. With a conjunctival Caesar, you are making this conjunctival flap, which is a fornix base flap. This flap is important because it will, at the end of the surgery, like an omentum or a hood, cover and stick by itself without any suture, so that there is no irritation and the patient is safe. As you can see over here, the tunnel has already started with the incision and the dissection of the sclerocorneal tunnel. So the conjunctival flap is very important. That is the first step. The second is the tunnel itself. So after making the conjunctival flap, the correct use of instruments and blades are very, very important. So as you can see over here, you are making a modified Frown incision. The modified Frown incision is made with a Bard Parker handle. It is 1.25 millimeters beyond the corneal surgical limbus, and the incision is made in half the depth of the corneal, the scleral thickness. A crescent blade is used to dissect. The correct use of instruments is very, very important. As you can see over here, the tunnel is a funnel. A funnel is very, very important because the funnel means that the external incision is smaller than the internal incision. And you can see the dissection in the pockets right now, which is occurring. And it is these pockets which allow the nucleus to be delivered safely. The dissection is continued into the cornea for 1.5 to 2 millimeters, and these are the side ports, as you can see, which help to put the AC maintainer in, and which is used for the AC maintainer and the second incision. This is the 3.2 keratome with which the entry is made, and it is cut while going in. And as you can see over here, the internal incision is much larger than the external incision, and that is the entry with the 3.2 keratome. Making of the tunnel, which is essentially a funnel, is the most important part of this. After that comes the stage of the capsulorhexis. The beauty of the capsulorhexis in SICS is that this patient has a fully dilated pupil, an immature cataract, the visibility is good, and a capsulorhexis can be made. It can be made with the capsulotome. I'm a left-handed surgeon, and as you can see, I'm making a capsulorhexis different or in the reverse direction as right-handers would make. And it can be done with a Utrata's forceps also. But the beauty of SICS is that it can be done without a capsulorhexis in case of a mature cataract or a hypermature cataract. It can be done with an envelope technique also. In case of a small pupil, as you can see over here, the rhexis is made within the pupillary margin. And then in this, it is very important to rotate and bring the nucleus out so as to ensure delivery without any subluxation. So capsulorhexis can be possible. The previous rhexis, as you were seeing, was under visco. And here, as you can see, it is in the Blumenthal technique. It is a visco-free technique, and it is under BSS. Because of the flap floating around because of the fluid turbulence, one has to get used to this technique, but it can be done without visco. This is a dye-assisted rhexis, as you can see, in mature cataracts. In mature cataracts, a dye is used, though the case shown here is phacoemulsification. In mature cataracts, as you can see over here, a Utrata's forceps is used to make a dye-assisted rhexis. So any instrument can be used to get a rhexis, and the beauty is that it can still be done without a rhexis in case of a hypermature cataract or in a case of a beginner. Hydro procedures are very, very important because what they do is they increase the nuclear size. It is a small 25 gauge cannula on a 2 cc syringe which has Ringerl acted or BSS. The nucleus whirls up slightly, and then it can be rotated outside the bag. The end point of hydro procedure is a golden ring shallowing of the anterior chamber. This is extremely important to free the nucleus from the cortex and the nucleus. So hydro procedures decrease the size of the nucleus. As you can see over here again, this is the wave, this is the golden ring, and this is the slight salute of the nucleus. So this is again in a small pupil. As you can see over here, you can gently do it by moving the iris a little bit. The nucleus comes up, and then with this itself, it can be freed, and with the needle, it can be rotated. As you can see over here, the needle is harpooned into the nucleus, and gently it is carouseled and it is brought into the anterior chamber. So this makes learning very, very easy. As you can see over here, this is carouseled and the nucleus is gently brought into the anterior chamber without damaging the pupil so much. Now, after this, what remains is the nucleus management. There are various techniques to deliver the free nucleus, as we can see with hydro procedures. What we use is the visco expression and the Blumenthal's technique. So as you can see over here, this is the glide, which is used in the Blumenthal's technique, and it helps to glide the nucleus over the tunnel outside the eye with the fluid pressure from the AC maintainer which is there, and that is called as a Blumenthal's technique. As you can see over here, it is nothing but a polypropylene sheet which helps the nucleus guide out by pressure and counter pressure. So after that, after the nucleus delivery occurs, there are various techniques which I will be discussing later. And as you can see over here, this is an AC maintainer. Though just for a depiction of the cortex removal, it is a phaco case, but in the same way that aspiration occurs with the AC maintainer and a single port hydro cannula, aspiration cannula, which is also called as the Lahani's cannula because he modified it. So a single port aspiration cannula is used to remove, because of the availability of two side ports and the incision, the 360 degrees complete cortical removal is possible. It's manual, it's cheap, it's autoclavable. The cost of these two instruments is equal to Simcoe, and hence it is financially viable. Finance should not be the most important thing as far as patient safety is concerned, but when it is available and it is so good, why not use it? So the irrigation keeps the bag inflated and the aspiration helps a complete cortical cleanup. And as you can see over here, the posterior surface of the capsule and the undersurface of the anterior capsule can be polished to prevent the PCO. So this is a complete case, but I need to just show. So as you can see over here, this is the cortex aspiration in this patient. So here the nucleus is being removed very nicely with visco expression technique. And as you can see over here, I'm a left-handed surgeon. This is the cortex aspiration in SICS. The AC maintainer is used and the cortex is aspiration. The bag is continuously inflated and the fluid flow allows little debris to come out. The side port, as you can see, can be used to remove the 12 o'clock cortex very, very safely. The bag remains inflated, the posterior capsule remains behind, and hence it is very easy to remove the cortex. The safety is very high. As you can see, strands can be removed from the posterior capsule. The posterior capsule can be polished so well, and hence in this, the incidence of PCO is very less. No need of viscoelastic is required, and under the flow of the AC maintainer, the IOL is gently put and rotated into the capsular bag. So which is very, very, and at the end of this, the hydration of the side ports is very, very important. The side ports are hydrated to ensure a tight wound. And as you can see over here, the size of the incision is, because it was a soft cataract, it is less than 5 millimeters. And then the conjunctival flap is posted back and placed back, and the subconjunctival incision is given. The conjunctival flap is put back into position after removing the superior rectus stitch, which is very, very important. The take-home message is that one must observe, practice, and learn. A correct technique gives you very good results, and it is a smart SICS because the surgeon is smart. He takes the correct decision in favor of the patient. And if you know your SICS well, you are halfway to phaco because you have done the preliminary steps of SICS. Doing a good in SICS, doing the best for the patient and giving the best results is very, very important. And a happy patient is equal to a happy doctor. And ultimately, it is our ethics which count at the end of the day for doing the best for the patient. Thank you so much. Thank you, everybody.